So this training today that we're so excited to have you guys here for is part of our COVID-19 action trainings and webinars that we're doing. And so with the COVID-19 pandemic upon us, the faculty of Columbia University School of Social Work have mobilized to form the COVID-19 action group. So the mission is monitoring developments and disseminating information that can be helpful to social workers and the clients that we serve. So for today, our presenters is, we have Louisa Gilbert, she's one of our associate professors. Laura Fernandez, she's a clinical director at Sanctuary for Families. We are also really thrilled and to have Anadita Dasgupta, who's going to be our moderator, and she is an associate research scientist here at the Columbia School of Social Work, and she's with the Social Intervention Group. So with that, I am thrilled to turn over the mic to you ladies. Thank you.
Thank you so much, Tiffany, for all the incredible efforts you're doing in hosting this series in your team. And thanks to Associate Dean Desmond Patton for organizing this. It's really a pleasure and honor to be here with you and with my co-presenter, Laura, who is taking time out of her incredibly busy work at Sanctuary for Families, and with Anandita. And just before I begin, I want to thank a whole team of people who are behind the work that I'm presenting today at the Social Intervention Group, which is led by Dr. Nabila Al-Bassel. So before we get started, I just wanted to learn a little bit more about you and where you're from. Just if there's a quick poll here. And I really want to thank you all for coming. I know these are really tough times, and just showing up I'm very thankful for your presence, and look forward to your questions and discussion. And I do want to say here that I'll be talking for about 40 minutes, and then Laura will talk for about 20 minutes, which will leave about a half an hour for your questions. So as Tiffany mentioned, please put your questions in the chat box. Unfortunately, I'm not so good at toggling between presenting and looking at the chat box, but I know Anadita is going to do an incredible job of culminating all the questions. She can also answer a number of clarifying questions because she's very familiar with the work that we're doing. She's been part of it. So. I'm just going to go to the next. So we have the results. We have a range of people from different settings, a lot from healthcare and social service settings. That's great. So let me just go on to another poll here. Let me go back. Wait. So if you've been working with survivors of domestic violence, and I realize many of you haven't, how many years have you been working with them? Okay, so most haven't, which is that's really helpful for us to know, and we hopefully you'll learn more through this presentation. Let me just go to the next one. So the next question is, how confident are you to screen women for intimate partner violence and link them to services? Okay, here we have a range too, which is great. And I hope throughout the course of the presentation, you'll also feel more confident in screening women for intimate partner violence and linking them to services. So today I'm going to briefly talk about the prevalence and define the different types of intimate partner violence, so we're all on the same page about definitions, and then really delve into how the social distancing and economic effects of COVID-19 are creating a surge in intimate partner violence. I'll introduce a syndemic framework for understanding and addressing the co-occurring COVID-19 and IPV pandemics and their structural drivers. And then I'm really going to focus on WINGS, which is a screening, brief intervention referral to treatment model that's been used to identify and address intimate partner violence among different populations of women, and talk a little bit about the future directions of WINGS in the times of COVID. So what is intimate partner violence? WHO and CDC have defined intimate partner violence as a constellation of controlling behaviors that includes physical, sexual, psychological, and economic abuse and threats. And many of you may be familiar with the Duluth power and control wheel, which really puts these all together. What I'd like to, I particularly like this graphic of the power and control wheel because it shows that we are all, our intimate partner relationships are all on a spectrum, from equality where both partners have equal kind of say in every single sphere, and to more harmful relationships where one partner really is exerting power and control in multiple domains. For me, it's always useful to think of it on a spectrum. So in terms of prevalence rates, we know in the US, 1 in 3 women experience physical or sexual abuse by their partner during their lifetime. And I also want to mention that 1 in 7 men experience such abuse in their lifetime too. In recent years, the number of intimate partner violence cases has spiked, making up more than half of all serious violent crimes in the US in 2018. And I want to say every day, 3 women in the US are murdered by their partner. And there are some racial ethnic disparities. The rates are highest among Native women, followed by non-Hispanic Black women and white and Hispanic and Asian Pacific Islanders. And I'll talk a little bit more why these racial ethnic disparities exist in the presentation. So intimate partner violence varies culturally. I mean, there's huge variations in the forms that it takes, and it covers a wide range of dating, sexual, and marital relationships, all the way from, you can think about teens and what hookups mean, to elderly couples who've been together for 60 plus years. And the data show that prevalence rates are similar among women in same-sex and heterosexual relationships, but higher among both actually women and men who identify as bisexual. And I want to also make a sort of qualifying limitation of this talk is that we'll mostly focus on women survivors who identify in heterosexual and or same-sex intimate relationships. And in this by women, I mean anybody who identifies as women, cisgender, transgendered. So here I want to talk a bit about where we've seen pretty alarming spikes in domestic violence across the US. And in New York, here in New York State, domestic violence reports are up 30% in April 2020 compared to the same time period last year. And in March, it was up 15% compared to last year. And across the US, we've seen a sharp rise in the number of domestic violence calls made to law enforcement agencies. And Google has also reported a 75% increase in internet searches relating to support for abuse since COVID lockdown. And here on the right, New York State is responding, getting out messaging about domestic violence and really focusing on text and chat options to reach women at risk. So what we're experiencing here in the US is going around the world. And intimate partner violence is not an epidemic, it's really a pandemic. And where COVID began in Hubei province in China, they've recorded a tripling of domestic violence reports in February 2020 during the COVID-19 quarantine. France has also seen an increase in reports of domestic abuse in Tunisia in the first 5 days after people were ordered to stay in. Calls to a hotline for women experiencing abuse increased fivefold. And in Spain and India, where they saw interesting trends, they saw that initially the calls were the same, but once they went to text-based services, there was a huge jump in spike in reports of domestic violence. So the most comprehensive study I've seen so far on the impact of COVID-19 on domestic violence was conducted by UNTF, where they did a rapid assessment interviewing 122 NGOs or government agencies in 69 countries in April 2020. And what they found, significant increases of reports of violence since COVID social isolation restrictions, but they also reported women experiencing violence faced major barriers in accessing emergency care, police response, and orders of protection. And you can imagine all of these systems are down and overburdened with COVID. They did, however, also find on more a positive note that a lot of these programs are really pivoting using technology, social media outreach, chat-oriented 724 hotlines, and deploying domestic violence resources and services in sort of mainstream spots where people can access, like grocery stores, pharmacies, and the streets. And I'm really excited for you to hear Laura talk about what Sanctuary is doing in this regard. And on the right, here are two women in the Bronx passing out domestic violence pamphlets and really just being out there. I want to say this is not new. We have seen similar surges in intimate partner violence found during other pandemics. Ebola increased, and other disasters, Hurricane Katrina and Deepwater Horizon. So we know we really need to redouble efforts to reverse this trend. So this is a little bit of a busy framework, and I just want to talk about all the ways that COVID is increasing intimate partner violence. Many women at risk for intimate partner violence may be currently facing a perfect storm, finding themselves sheltered in homes with a violent partner during a time of severely limited contact with the outside world. And for these partners, it's a time to exert all types of abuse that I just mentioned in that power and control wheel. COVID-related lockdowns enable them to impose 724 surveillance of their movements, and also can restrict women's use of social media, internet, cell phones, and really hampering the ability of women to reach out for help electronically. Furthermore, the safe sanctuaries in our communities, schools, primary care centers, libraries, and churches, they're all shut down and have been shut down. And these are places that women also turn to for safety and for help. I also want to mention that the huge economic distress from COVID, unemployment of both the survivor and the partners, we know unemployment is a huge risk factor for intimate partner violence. And just the daily household and parental stress of managing children and maybe trying to work and doing other things also creates a trigger for intimate partner violence. Finally, we've seen huge upticks in alcohol sales across the country, across the world. And we know from the domestic violence literature that alcohol, and particularly binge drinking, and now binge drinking at home, is a huge risk factor for violence. And we've also, by the way, seen upticks in gun sales in this country. And gun sales are probably the most single one predictable risk factor for lethal violence. So that being said, at the same time, we're experiencing major service threats to IPV services. At the same time, there's an increased demand. There is, programs are struggling with decreased capacity. Many of them are working remotely. A lot of the residential shelters are up and running, but most of the services are provided to, out to non-residential clients. And for the domestic violence staff, you saw them out there on the streets. They're working, they have kids at home. The threat of burnout is huge. I've already mentioned that there's been delays in emergency response and court capacity for orders of protection. And a lot of the programs are now facing major funding shortages. But I don't want to be totally negative. There are some incredible service opportunities, building online telehealth capacity of intimate partner violences, and really getting out to women who may have never reached domestic violence services in the past. I find that very exciting and something we really need to capitalize on now to kind of decolonize the social work agency presence and getting out and meeting women where they're at. And in the end, if we really want to reverse this upsurge, we're going to have to do everything that it takes. And there's several metrics that I think we really need to constantly keep monitoring and seeing out. What is the frequency and severity of intimate partner violence? What are the number of people being able to access IPV services? And what is the equity in IPV services, access to IPV services look like by race, gender, sexual orientation, and class? These are major issues. Go forward. So I want to briefly introduce this syndemic framework, which has been really helpful for me for understanding and addressing all the biopsychosocial mechanisms linking COVID and intimate partner violence. Meryl Singer in 1996 first came up with a syndemic framework to look at the connections between substance abuse, violence, and AIDS. And he defined it as when two or more epidemics, and I would say both COVID-19 and intimate partner violence are pandemics, synergistically interact with each other and are reinforced by harmful social conditions that contribute to the formation, clustering, and spread of epidemics and excessive burden of disease in minority communities. So here, this is another kind of visual depiction of what I think this COVID-19 IPV syndemic looks like. COVID is a virus. They're there on your left. It knows no racial ethnic boundaries as to who it infects, but we know that it's really disproportionately affecting people of color. And it synergistically interacts with IPV, and both pandemics are being driven by other structural drivers. And first and foremost of those, it includes 400 years of the pandemic of deeply entrenched anti-Black racism, which is closely linked to the huge income inequalities in our country, which are fueled by corporate welfare policies, as well as lack of affordable living wage policies and many others. Also, we know that racism is closely linked to our epidemic of mass incarceration in this country, or I should say selective mass incarceration of Black and brown men and women, and lack of universal health care. So these overlapping structural drivers are fueling huge racial disparities in how the co-occurring epidemics play out. So here in New York City, we know that Black and Latinas having much more time social distancing, as a number of speakers in the series have already pointed out. We know that there's a greater proportion of Black and Latinas working in essential service jobs, working in MTA, mass transit, who rely also on mass transit to get around and are subject to more crowded living conditions, all of it which make it very difficult to practice social distancing. We also know that at the same time, policemen were handing out masks to people in Chelsea. They were handing out summons to people in Brooklyn for not social distancing. And not surprising, 95% of the first 125 summons went out to Black and Latina people. We need to think about how we can transfer the funds that are going to the police department to do that to the communities to protect themselves. And I'm very kind of encouraged about where these protests are going, but it is incredibly important for fighting these racial disparities here too. So we also know that there have been Black and Latinos are less able to get tested. When they go to the hospital, they're less likely to be accepted in the hospital and delayed treatment for COVID. They're much more likely to have underlying conditions for COVID, diabetes, hypertension. And so we've seen huge, disproportionate cases and hospitalizations and deaths among Black and Latino. At the same time, I want to say that there are huge IPV disparities, and access to health and telehealth care is, we know that Black and Latino are less likely to access it. And research also shows that Black and Latinos are also less likely to call the police and during violent episodes and access IPV services and the courts. And frankly, I can only imagine what it would be like to be calling these services, to call the police during a violent episode if I were Black or Latino, given what's going on right now, and their fears of their partners being, incarcerated and hurt. And it's just, it's very understandable and very tough. So the other advantage of a syndemic framework is that it highlights the geographic clustering of COVID-19 and IPV. And here on the left, you can see the total number of COVID-19 cases here in New York City by zip code. And where you really see it is in the darker purple zones show the hardest hit communities, which are largely Black and Latino communities here. And the ones that have been hardest hit are actually in the South Bronx, Morris Heights, and High Bridge, which are some of the poorest neighborhoods in the country and 95% Black or Latino. And here, they have double the rate of COVID cases as Manhattan, and double the rate of deaths. They are also have the highest rates of diabetes and hypertension, which predispose them for complications of COVID. And their life expectancy in these two neighborhoods is 5 years lower on average than Manhattan. So here on the right is a look at what domestic violence as a driver of homelessness is in New York City. And it shows the percentage of families with children eligible for shelter due to domestic violence by community district. It's a bit old, from July 2014 to 2015. And I want to point out here that we have a real lack of real-time surveillance of domestic violence and being able to map it like this that's available to the public. And I do think that that is something is a really important point to follow up on. So, I mean, next steps, I think, for tackling this endemic, critical to be able to conduct routine surveillance and mapping of real-time IPV reports along with COVID-19 cases, hospitalizations, and deaths, to identify these geographic clusters burdened by both IPV and COVID-19. That enables us to really target resources to those neighborhoods, mobilize those neighborhoods, and let them take the lead in protecting themselves. There's also a huge need for increasing public awareness on increased risks for IPV during quarantine. Here's one media campaign that I think New York State did on the right, and how to safely access support through social media and traditional media campaigns. It's, as I mentioned before, I think if we're really going to reverse this upsurge in intimate violence, it's really going to take conducting innovative outreach to engage individuals at risk and link them to IPV services, using trusted sources in the community, which may be just on non-traditional sources that we've thought of before, and safe technology platforms to meet women where they're at. And here I'd really like to, say we really do need to train on IPV screening, brief intervention, referral to treatment service models. And I think there's a huge opportunity to co-locate some of these IPV services in the massive rollout of COVID-19 initiatives, of both prevention and contact tracing and testing initiatives that are being rolled out all over the community. So I would say our first and foremost urgent need is really to identify individuals at home who are at risk of IPV and in high burden communities. So I'm actually really reminded of this challenge that I faced more than a decade ago, where our work was showing us that only 6% of women who use drugs, who needed IPV services, were actually receiving them. And all of our work has largely focused on women and men who use drugs. So the challenge for us then became, how do we find the 90% or more of women who use drugs and who are experiencing intimate violence or dating violence and link them to violence prevention services? And we knew that that meant getting out of domestic violence service, traditional domestic violence service boundaries and substance use treatment boundaries, and really getting out into the community, where we knew that there were, in community corrections and emergency care, saw large numbers of people experiencing domestic violence and substance misuse. We also thought about HIV/STI prevention care for the same reason, and then also thought about virtual media. So in 2011, we developed and evaluated a computerized self-based tool of WINGS, which is a screening, brief intervention, referral to treatment model, with women who use drugs in community corrections in New York City. And we found it to be equally effective in identifying and reducing risks for different types of violence as the traditional WINGS intervention, which was delivered by a facilitator. And around the same time, we conducted another randomized controlled trial comparing a group-based HIV prevention intervention, WORTH, that integrated the computerized self-paced core components of WINGS and found it was effective in actually reducing different types of violence of the 12-month follow-up compared to a wellness promotion control group. Over the past 10 years, we've adapted and evaluated WINGS with different marginalized populations of women at risk around the world, including women who engage in sex work, women who are refugees, women who are HIV positive or are internally displaced. We've integrated modules of HIV counseling and testing into WINGS, and overdose education and naloxone distribution into WINGS. And we've also expanded WINGS to address different types of gender-based violence. WINGS has been implemented in a wide range of settings, including harm reduction programs, primary care clinics, and community-based organizations around the world. And Dr. Anindita, who is moderating, is actually currently working on a brief sexual productive health and mental health screening modules that can be integrated in WINGS in India. If you get a chance, you can ask her questions during the question and answer period. And other members of our team are adapting WINGS for sexual minority men. And WINGS has now been translated into 8 languages and is currently being implemented into 6 countries. So WINGS is really relies on motivational interviewing that many of you may be familiar with. It's a client-centered method of communication for strengthening internal motivation for change that really relies on OARS. And OARS is a core clinical skill that O stands for open-ended questions, A is actively affirming and validating, R is reflective listening, and S is summarizing. And the whole approach of it is to reaffirm women as primary agents of change, experts on their own problem. And WINGS also really takes a harm reduction approach to improving relationship safety, recognizing that many women will want to stay with their partners. So WINGS is also consistent with psychoeducational principles that were presented earlier in the series. It engages women as equals and really tries to create this learning exchange of information and thinking and reflecting together. It also really recognizes racism, classism, and heterosexism as structural drivers of violence. And then the whole point is really trying to evoke and draw the solutions and ideas for change from the women, and engaging and mobilizing key stakeholders from different affected communities to coordinate a community response. WINGS is also strength-based and with a focus on reinforcing resiliency and trying to data-driven and producing data to really help and identify structural barriers to resources and services. So as I mentioned before, it can be delivered as a computerized self-paced model or a computer assisted, or just a non at all off computer, offline, by a case manager, helping professional, outreach worker, or trained peer advocate. It's been delivered by all of those in the different trials that we've done. So the first core component of WINGS is really a brief psychoeducation piece, really walking them through that power and control wheel and asking them, really collaborative, what does psychological abuse look like for women in your community? What does sexual abuse look like? Using OARS to kind of, elicit and sort of affirm their experiences. Then it goes through, we have a validated screening tool which asks for both experiencing and perpetrating different types of violence and providing feedback on the risks. There's a brief motivational interviewing piece which really focuses on just eliciting what motivation they have to address intimate partner violence and improve their relationship safety, focusing on how the violence is affecting them, their children, and highlighting change talk. We then have a safety planning tool that incorporates physical, sexual, and emotional safety planning. And I have to say now during COVID, a lot of, I think it's important to be able to go back to women who've already done safety planning and redo it again because their options are much different. And then there's a piece of there's a social support network enhancement piece that gets women to really think about who can they turn to if they needed to a place to stay, or who could they turn to for housing, for money or emotional support and advice around how to cope with intimate partner violence. There's a piece where they go through and systematically kind of identify and prioritize their service needs around improving relationship safety, and then linkage to IPV and other services. And again, it's always giving them menus of options and reaffirming women to be able to just, decide on their own and be the agents of change. And then we use SMART goals to do goal setting to improve relationship safety and what they want to do in the next week to reduce their risks of intimate partner violence. So here's what the computerized self-paced WINGS model looks like. It's a web-based tool with audio that can be delivered on smartphones or computers. My colleague in Kyrgyzstan has actually developed an app for it, and we're hoping to do the same here. It covers all the same components using interactive exercises, videos, narrative characters, and computerized feedback. There is a demonstration video here, and you will have the slides later on that you can access. So this is the first part on just raising awareness about different types of violence. And this is, we have narratives from 3 different women who experienced severe violence, and they just talked about their experiences. And for a lot of women I watched taking the computerized self-paced tool, a couple of them started crying saying, that's me. And so I think it is, as we adapt it to different populations, this piece can be adapted too. This is what the screening looks like. This is what the safety planning. Here's the support map exercises, and then the goal setting to increase support, goal setting what they want to accomplish in terms of what they want to do and reducing the risk for intimate partner violence and improving relationship safety, what kind of resources they need, what service needs, prioritizing them, and then linking them to services. So over the 10 years that we've been doing research on implementing WINGS, I think we've learned really 6 core things that are essential to not only initiate implementing WINGS, but be able to sustain it in different types of organizations. There is an 8-hour training on WINGS to kind of be more fully up to speed, and there's an extra 4 hours if you want to collect data and use that to sort of really direct, to have a more data-driven approach. Organizational leadership commitment is absolutely essential. And I think leaders can play a huge role in making sure that staff have the time and the tools and the confidential safe space to do their jobs and to be able to implement WINGS safely. And then I think, particularly for non-DV agencies, it's really important that they have, are coordinated and linked with IPV services. And so there's a huge range of IPV services that have come out with women going through WINGS, everything from reproductive health to housing, trauma, mental health, legal, harm reduction services. But these are all places that you could potentially be deploying WINGS and linking them to IPV services. The concept is that there's really no wrong door. So some of the potential benefits of this computerized self-paced model, and I'm thinking especially now with COVID restrictions, is that it does provide a greater sense of privacy and confidentiality where women are fearful of disclosure, even on a phone conversation. And I think it may extend the reach of intimate partner violence services in overburdened high caseload settings like probation or emergency departments where staff just don't have the time to deliver wings. And as I mentioned before, it can be culturally tailored and translated into different languages and settings where there's a lack of bilingual speaking staff. And really, I think one of the biggest benefits from wings is that it's been used to aggregate data on different types of violence that groups are experiencing to inform policy and programs to address intimate partner violence and gender-based violence. So next steps for wings, I really want to focus on a data-driven approach towards tackling intimate violence in communities. And for that, we really need to get better data on the different types of intimate partner violence and gender-based violence and document the scope and severity and public health threat of violence against women in communities hit hard by COVID. I also think that to integrate IPV prevention and brief interventions like wings into COVID prevention testing and contact tracing initiatives, as I mentioned before, is a huge opportunity that we need to take advantage of. And if we are going to reverse this spike in domestic violence, we need to do more. And this will also require universal access to internet and smartphones, using social media to encourage groups to connect and direct individuals to trusted resources for all types of supports. So just moving upstream from here, I think if we are, how are we going to reverse this endemic here that you're seeing and the real surge in violence along with COVID cases? Is going to require a really robust community response to mobilize key stakeholders in high burden communities to advocate for IPV COVID prevention resources, to coordinate the community response, and then to work together to tackle structural drivers of racism. We should be out there protesting all the COVID related deaths among Black and Hispanic folks in New York City and around the world. These are deaths caused by racism. Then I think it's incredibly important to target economic assistance and cash transfers to high burden communities using data-driven approaches. Maybe as part of the effort is possibly to take as the initiatives to defund some of the police departments and transfer those funds to communities. This would be a priority need for that, and a real need for that. We really need to, I know this is a time where New York State is facing major cuts to their budget and are being asked to cut the budget across the board. This is not the time to cut DV services. We need to increase federal, state, and local funding for DV agencies to really meet the surge in demand, as we sort of focused a lot of the resources to fight COVID. And we also really need to ensure that DV staff have the adequate financial and emotional support as critical essential workers in the COVID-19 pandemic. They are in the front lines, and I just want to take a moment and really applaud them for the incredible work that they're doing. I just wanted to thank you all again for showing up, and urge you to get in touch. And there's give you information about our SIG-WIPES website and Project Wings.org that both has information on wings. Also the COVID Action Resources website that is doing a lot of work around organizing around the racial disparities. So thank you. And just one last poll question here. And I'm delighted to turn it over to Laura after this. Oh, sorry. I think I may have stopped sharing. Do we have here we go. Do we get okay. A little bit more confident. That's good. And again, we do have an 8-hour training. If you're interested, look us up on the SIG website. Thank you very much again, and I'm delighted to turn this over to Laura now.
Okay, I'm delighted to take over and begin this process as soon as I can figure out how to get my slides to take over the whole thing. Okay, play. Well, it's super exciting to be here and with such a group from such a diverse area. I'm mainly talking about my experience as an on-the-ground provider of domestic violence services in New York City. I'm the clinical director at Sanctuary for Families. So at Sanctuary, our mission is dedicated to the safety, healing, and self-determination of victims of domestic violence and related forms of gender violence. We do work with clients who are victims of trafficking, female genital mutilation, forced marriage, and other forms. And we believe we provide comprehensive services to clients and their children, and also outreach, education, advocacy, and striving to create a world that is free from gender violence. The comprehensive services provided by Sanctuary include the clinical services, which I'll be talking about. We also have a legal department, which provides a wide range of legal services, including family court, divorce, immigration, criminal advocacy around trafficking charges, and housing support, many other legal supports. And we have an economic empowerment program that helps clients be connected to living wage jobs with the understanding that poverty is a real driver. It really prevents our clients from getting out of violent relationships, and it really prevents them from accessing all that they deserve to live full lives. So just to have a sense, Sanctuary for Families has about 200 plus employees. We served 13,200 survivors in 2018, do a lot of outreach, and we have crisis and transitional shelters for over 60 families in 5 locations. And this is sort of gives you a sense of how many people all of a sudden had to pivot from working with clients to working remotely. I will say that prior to March, we had not really had a robust remote working plan because our services were really mostly almost 100% in face-to-face work with clients. And it was such a quick shift for us that one week we were planning to finish groups and continuing to see clients. And then like in one day to the next, we're like, okay, everyone has to go remote. But before I get to talking about that, I'll talk a little bit about our clients. Our clients, we serve a majority immigrant clients who are residents of New York, and most of our clients, 82% of our clients live in poverty. They represent 160 different countries, with Mexico being the country the most represented. And our clients are some of the most marginalized people of color in the city who are, many are undocumented, and they really are victims of a lot of structural issues that prevent them from accessing all the benefits of the city. So as I was saying, at Sanctuary, we had to do a very quick pivot to a mostly remote service model. So one day we were planning to continue groups, and the next day the majority of staff were set up to work from home. I will say that they were set up without a plan. I mean, people just didn't come to work the next day and all of a sudden had to do whatever they could from home. Our staff was amazing in quickly figuring out how they could make their home equipment work for work, how they could set up Google numbers and do whatever they could to continue to communicate with clients. We had to keep our shelter fully functioning. We have to have on-site care 24 hours a day, but we did plan around a reduced number of staff so that staff would reduce the risk of, of traveling for themselves, but also reduce the amount of people in the shelter building, since that increased the risk. And staff began connecting with our clients remotely. And the immediate need we had in New York was just the huge immediate need for emergency goods. We had so many clients who were in immediate food insecurity. I mean, their connection to, they had food insecurity prior to COVID-19 and prior to the pandemic, but the intensity at which they went to immediate crisis was a very intense experience. A lot of our clients, especially our undocumented clients, worked in ways that immediately became unsustainable. Either they were told they couldn't work. A lot of them did home cleaning, childcare, other frontline jobs. So they went from having some minimal source of income to having zero income. So we spent a lot of time with our case managers assisting clients with urgent needs, and immediately using Zoom and GoToMeeting and any other application we could. I think one important thing for all of us who've been providing services remotely is we need to find a way to connect with the clients, but we also really need to find a way to connect with each other. Doing this work in isolation from your home is really very difficult. We had a very much of a team model where we met together, supported each other, helped each other debrief intense situations. So it was really important for us to figure out how do we quickly do that. And I think Lisa already covered this, but the trauma of gender-based violence was really added to the trauma of COVID-19 for a perfect storm, combined with the trauma of racism and structural barriers in our city. So we had the unique challenge of our staff trying to provide emotional support to and safety planning to clients around the domestic violence, while at the same time trying to deal with all the complexities of the stay-at-home order, of COVID-19. Every decision was so fraught with what is the right decision. And I will say that while our clients were going through these decisions, our staff were also making these life decisions for themselves and their loved ones. So it was a very, very uniquely challenging time. And I will say, back to Louisa's slide where she, really showed the ways that COVID-19 goes hand in hand with a lot of the factors of domestic violence, the isolation, the, economic insecurity. So for a lot of our clients, they say COVID-19 was like another trauma. It was like re-traumatizing and bringing up all these feelings for them of all the traumas in their life. We've already covered that shelter in place is incredibly dangerous for those in unsafe relationships. It's like being trapped with your abuser with no space for either of you to have space away from each other or to be in community with other people that could be supportive to you. I will also say that the pandemic has made regular decisions incredibly challenging for all of us. I mean, do you have someone watch your child while you go to work? Do you visit with a relative? Do you use the subway or don't use the subway? Or how do you get around? Do you go grocery shopping? Do you wait for delivery? So just every decision in New York City is fraught with complexity of are you putting yourself at risk? Are you putting others at risk? And then you add the complexity of domestic violence. It was really hard. One of our most intense things was around custody and visitation. Do you allow your child to go with go on court-ordered visitation with their partner? Are you confident that your partner is using social distancing? Are you going to put your child at risk taking the subway to meet your partner in a public location? A lot of our clients use school as a primary place for pickup and drop off on court-ordered visitation, but now schools are home, everyone was at home. So it meant where is a safe location to pick up and drop off? So these basic decisions that are hard on a regular day became incredibly difficult. And I will say that at the same time that many of the traditional systems that support victims were really impacted. And I will say in New York, one of the first systems that we could really see the impact was the court system. A lot of our clients rely on family court to get orders of protection, to get other kinds of, custody and visitation orders. And we went from, our family court on a good day pre-pandemic was incredibly overburdened and unable to kind of move quickly and address things because of the volume of litigants and people in court and the lack of judges. But we went from having 90 sitting judges to having three judges that were doing work remotely. So that meant that many of the normal aid that our clients could get was impossible to get. The first message went out that clients couldn't even get an order of protection, that it was only life or death. So a lot of advocacy had to be done with the court to say that, that people needed the court to be responsive, that it can't just be a life or death. People need to access order protections. People need to access the support of that court can bring. We also had people making decisions that seemed impacted by COVID-19 that weren't sort of it brought quandaries that people didn't know how to handle. So they made decisions that to us put our survivors and victims at more risk. Like, for example, we had a client who was very badly assaulted by their abuser and had some threats made, and there was an order of protection put in place, but the order of protection allowed their abuser to come back and sleep in the house, which would have been unprecedented before the pandemic. But the feeling was, well, there's nowhere for that person to go safely. We can't take them out of their house. So that we were lucky that we were able to put the client in a hotel while we advocated for the client in court. But those kind of like reactions that we were not used to, and sort of like, how do you quickly, deal with these new obstacles, these new challenges, these new ways of thinking. So, and I will say that even though things are slowly getting, back to order and we're slowly opening up, that the systems are definitely not able to provide relief at the same rate they were pre-pandemic. And again, pre-pandemic, the systems didn't work that well anyway. So it's just a big challenge, and it requires a lot of time and advocacy for service providers. So I just want to say, in New York City, our shelters have remained near full occupancy, and we had to balance in our program the balance of taking in new residents with keeping some space for potential quarantine needs. We have clients in shared units, so for anyone who runs a shelter, like if one family gets sick, how do we separate them? How do we allow a sick family to have the space to themselves? So we've been very lucky that due to all the social distancing that we put in place, all the increased cleaning, that we have not been hit with any kind of a COVID-19 situation in our shelters. But I think everyone running residential programs lives with that fear, and it's just something to really continually to be vigilant about. Even though our staff are coming on site to provide the basic, our residential aides are keeping the space safe and providing regular care, our facility staff is cleaning the building. A reality is most of our counseling and case management is occurring by phone. Even when staff are in the shelter, they're still using a phone or a telehealth platform because we just want to reduce the amount of face-to-face contact. And then, I think the biggest thing we've had to pivot to is also really supporting parents who are trying to help their kids do remote learning. So even though normally our focus would be on domestic violence or recovery from the trauma, the reality is right now a lot of our clients, both in our shelters and non-residentially, need help understanding how to use remote technology and how to deal with the frustrations of parenting while trapped in a house with having limited resources. We were also lucky that we had the ability to stockpile food and do a lot of contingency planning so that our residents would be would minimize how much they had to leave the building. We were lucky that in New York City, the DOE, our Department of Education, made a plan to drop off school lunch at our shelter. So for those getting school lunch, they can get the food at the shelter without having to leave and go to the school, which is another amazing benefit. So counseling, immediately after pause, after we sort of went into our lockdown, there were, the first thing we had to do was get all our clients on the phone and check in, sometimes multiple times a week, sometimes multiple times a day, because people were in such panic about the COVID-19. And, in some ways it put the domestic violence a little bit on the back burner initially, because people were just so fearful about their health. But obviously the two issues go hand in hand. We have moved to utilizing Thera platform as using telehealth platforms, which I'll talk about later, to provide counseling, to provide video. For some clients, that's really important. I will say that a lot of our clients are having real technical issues. We have clients, undocumented clients who don't have an email address. It's very hard for them to even use the platforms that exist based on their limited technology, and we have a few clients that don't have phones. So part of our work has been, how do you help that client access emergency funds to get a phone or some means of communication? Because for clients without any means of a phone, a tablet, anything, they are completely isolated and cut off from all access to services, both our services, but generally services in the city. And again, there was increased safety planning for high-risk clients. A lot of our clients that were at high risk, even when there was shelter availability, and they could enter the shelter. A lot of clients had real fear leaving their home where they felt safe from COVID-19 and going into a shelter where they didn't know who would be available. So that we had to do a lot of work around that, and also just like clients do whatever they feel safe at that time. Sometimes for some clients, leaving in the in the middle of COVID-19 was not the best plan for them, and they had to figure out how they could be safe in their home until they felt better about leaving and going into a shelter or another kind of a plan. So the platforms that we came up to support the work, we're very lucky, and I think for any provider who hasn't gone down this road, we started exploring all the free, a lot of the platforms made free trials available, and we tried them all because we were like trying to find what would work with which clients, and that really allowed us to get our staff input. So the platform that we're using most broadly is TheraPlatform, which is designed for work with children. So that allowed our providers to do things like they can share a screen and draw pictures, they can use videos, they can read stories together. So that allows them to be more interactive. It was very hard to get children to come to the screens at first and to focus on counseling or talking counseling, since they were used to doing play therapy in the office. But we found that with TheraPlatform, we can at least have some techniques to engage them. But again, for TheraPlatform, you have to have an email address, and it's like some technical steps to get it started. And some of our clients couldn't handle that, so they prefer DoxyMe, which is very simple, and all you need is a phone number. And then what we've also moved to, and I think someone asked earlier in the Q&A, like, what about how do clients communicate who can't call? We found that texting has been the way that people have been communicating. So we found a service called Resource Connect that is a communication platform that allow clients actually to email or text, and it's encrypted, and it can be set to to erase itself from all devices after a period of time. And so that, I think, has been the way that some clients are communicating to ask for help, and not at our agency, but I am aware of a sister agency where a client used safe texting to indicate that they were in like life or death danger and that they wanted the police called, and that allowed the provider to call the police and get the client the help they need. So I think it sort of behooves all providers to start looking into this, no matter where they are in lockdown or not lockdown, just because we don't know what the future holds for other times if we may have to go on lockdown or be using remote technology. So having a way for clients to text and to have it be safe and encrypted is critical, because you don't want clients to leave that record on their phone and have that be something that the abusive partner would find. We did work with our survivor leaders. We have a group of survivor leaders who are former clients who are become advocates and agents of trying to change and support other clients. And they came up with a COVID-19 safety planning guide, which has some of the same elements of a regular safety planning guide, but sort of was tailored for COVID-19. So the importance of code words takes on a whole new life when you may be trapped with your abuser. So if people in your life, if you have people that know, whether it be a service provider, friends, or family, who know that if you say a certain code word, that means that you need the police called or you need a certain action taken or you're in danger, that has been a critical way to sort of alert people of need for help. The concept of the safest room, like when you can't flee and leave your house, like how do you really look at how can you remain safe in your space if that's where you're trapped? The need for social support. I think, initially my counselors felt very powerless to do much for clients. And I kept telling them, just calling them on the phone and being like a supportive person that can speak to them, even if it's for 15 minutes, like you are providing a service, because the isolation, being a victim of gender-based violence and being trapped in a house and not able to have any connection with any positive people in your life is really very, very hard. And so any kind of social support that you can help clients connect to virtually, virtual support groups are now getting up and running, even doing virtual yoga, virtual anything that a client can do that will connect them to other people outside of their home, I think is very important. Creating a peaceful space, so having a place in your home that you feel peaceful in, or creating peaceful images or anything, affirmations, even if you like put the affirmation in a secret location that you know where it is, but anything that a client can do to kind of keep their spirits alive. And I think holding on to your plan, they talk about like kind of keeping your plan memorized, but I think also for a lot of our clients, it was like holding on to their plan, like in their mind, like psychically knowing that, you know, the lockdown wasn't going to be forever, and that there would be hope and a chance for like change in their future. Because I think it felt, since we did not know when the lockdown would end or when the pause would end, I think it felt for a lot of clients like this is the end, like I'm trapped here forever. So it's important that they hold on in some level to the idea that you know, there is going to be hope, and things are going to, you know, there's going to be change, and a possibility of them getting support down the road if they're not able to leave at this time. I put some immediate resources. These, of course, are only for if you live in New York City. I wasn't thinking of how many people were going to be sharing from all over the world. I think, you know, the key thing for all service providers who are, you know, screening domestic violence victims or victims of gender-based violence is that, you know, what are your local, you know, your local resources. These are our hotlines. You know, shelter, the city's 24-hour hotline is still the best bet for getting clients into shelter. We have a model here in New York, the Family Justice Centers, that used to be a walk-in model, but now is all gone remote. So clients can call 311 and get connected to that Family Justice Center and get all the help remotely that they would have gotten in person. And certainly here at Sanctuary, we have our clinical services. I have that information in our legal services. But again, you know, it's kind of figuring out where are the hotlines in your area, where are the like point of contact that you can connect a survivor to. Because once you screen a survivor for domestic violence or are aware that it's happening, you clearly want to link them with the resource that can help them. And all of these resources are, you know, have pivoted to being able to kind of screen people and help people remotely. So, you know, challenges. What are the challenges? The digital divide is preventing many of our clients from full participation in remote counseling, schooling, or accessing benefits. I've become like Wi-Fi for all is like my new motto, because it's like in our new world, I mean, it was before this already, but in our world, like not having access to Wi-Fi, it's like cuts you off from everything. And it just, so many of our clients are struggling with, even if they have a laptop, they don't have the Wi-Fi to be able, they were using the Wi-Fi at the library, they were using the Wi-Fi at their school, you know, or they were connecting in some other way. So I think it's really the structural barriers that, and the economic barriers that we see for some clients really have become super, super apparent in this current climate we live in. I think, you know, the disproportionate impact has been said, but we can't say it enough. Like so many of our clients, and I would also say our frontline staff, many of our staff at our agency are people of color, and our frontline staff, especially in some of our childcare residential aid positions, you know, they are also represent sort of, yes, they're working for us, but they're getting very, you know, lower wages. They don't have the same like kind of access to resources. So the disproportionate impact of COVID on them and on our clients has just been like shocking. The amount of deaths that have touched them personally has been incredible, and the importance of taking time to support our staff and to give them space, because it's impossible to be fully focused on work, you know, 5 days a week while you are like dealing with loved ones that are sick and family members and the distress kind of people in your community. Obviously for us, there's the safety. We have a significant portion. We're lucky that about 80% of our clients have been able to continue to go on in some form of counseling or services, but we do have a portion of our clients have no safety or privacy to continue working with us, that it's not safe for them to get on a phone call or a telehealth platform, because they are being monitored 24 hours a day and living with the abuser. We've done everything from, if they step out for 15 minutes to walk around the block, making sure that we have a plan to, you know, be available to them in that moment. So I think really being flexible to where our clients are at is like absolutely critical. I mean, it was already an important value, but I think during this time, it's been absolutely critical. If a client has 15 minutes at, you know, a certain time, we have to find our way to try to make someone available to talk to them at that time. And I think we were talking about one of the challenges, a lot of these new platforms and technology, bring ongoing funding costs to agencies. And I mean, it was great. Everything was free at first, but to really fully benefit from them, you have to buy subscriptions, and, agencies are going to be experiencing funding challenges for the near future. I mean, many of us rely on government, which has less money, and private people who have less money. So we're all kind of expecting to have less resources and new expenses. We also, I would say that having more resources for client emergency needs is definitely something that agencies need to consider. That at this time, like, it's hard for a client to focus on their, trauma or domestic violence if they don't know how they're going to eat that day, or have diapers, or have their basic needs met. So really, we have been lucky that a lot of funders have stepped up and made emergency funding available. I will add that you have to be very creative as to how you get the aid to the client and have a receipt that satisfies your funder without ever having contact with your client. So we spent a lot of time finding ways to kind of do that. I mean, using gift cards, finding ways we can order things directly and have them shipped to clients' houses. Because in New York, we really didn't want any of our clients to have to leave their house if it was at all possible. I mean, I like also, like Louisa, to talk about opportunities that remote technology has made counseling more accessible for some clients. For some clients, the act of getting into leaving their home and coming to the office, the time that would take made it hard for them, and actually having remote technology available has been like a positive in their life. It's been something that, allows them to get help from wherever they're at, and not having to come physically to a location or be seen entering an office or leaving their neighborhood. So that's been a plus. And for our engaged clients, we've actually seen a decrease in missed sessions. A lot of clients are trapped at home, so of course that may have increased their participation. But I think what we've thought about is, if a client has 3 kids and one child is sick, that would prohibit them from, in the old days, that would have prohibited them from coming to our office. But they can actually engage in their remote session. It does, their sick child can be home in bed, and the rest of the family can still engage in services remotely. Our staff have also been participating in lots of remote training and opportunities that may not have been as available. We had one evidence-based training that was, before that you had to fly to where the training was at, or fly the trainer to you. But now, because no one's doing anything in person, we were able to do that training remotely, which was a greatly reduced cost. So I think we can take advantage of training and opportunities to collaborate and learn from each other at this time when we are doing it remotely. We're also grateful that regulatory systems that were previously opposed to remote services. I mean, a lot of our funders prior to the pandemic would not consider a telehealth session to be, we could not consider that towards our service delivery, because they did not recognize that. They felt it was an unsafe way. They weren't sure. So I think they've all had to very dramatically change that stance and allow us to do remote services, because it's the only way. And I think these changes are going to last well beyond the crisis and allow some clients to participate that wouldn't have previously participated. And it will allow us to have a range of things to offer. There are definitely clients who we will begin, as New York State starts opening and New York City starts opening, we will begin to make arrangements for some clients to be seen in the office, because again, there are clients who are completely cut off and unable to use remote technology. But we're very, excited to continue to have that remote counseling as an option. And that always innovative ideas have a big audience. Our survivor developed COVID-19 safety plan has been forwarded around the world and shared a lot. So I think everyone's looking for new ideas and new innovation. So I think when you have a good idea, there's the audience and the people are paying attention in new and different ways than they were prior to this. I think that is my presentation. So I can take off screen sharing and go back online.
Great. Thank you so much, Laura and Louisa. These were really great presentations and such a great overview on all the challenging and creative strategies that are happening right now to really address violence.
It's stunning, just staggering, just really amazing. Yeah.
So we have a few minutes for questions, and we just wanted to remind everybody that the slides will be posted shortly after the presentation wraps up today. And we're also answering some questions in the Q&A box as well. And then in the chat box, we're also putting in some links to resources. A lot of the questions have been, where can we get access to resources, which is really great. So links are in the chat box, and we'll have some more coming in a second. So one question I think Laura and Louisa, you both already addressed to an extent, but I just wanted to open it up one more time, is really this concept, this issue of reporting experiences of violence using telehealth or crisis hotlines when survivors are sheltered in place with their abusers. And so I know you both talked about this a little bit, but I just wanted to open it up in case you wanted to add anything else to what you've already shared.
Sure. I mean, I think Laura has more on the ground experience with this, but it really goes back to the digital divide that she showed in her slide. And I think we have to think of this as a huge structural barrier that we need to tackle head on. New York City has a start with those Linksys stations where you can get internet access outside, but that's still problematic for people who don't even have the phones to do that. So I think as part of level is really tackling racism and structural inequalities is we need to make sure everybody has a smartphone and access to to Wi-Fi, because education relies on it, health relies on it. We're only going in that direction. So at a big level, I would say that is, just of paramount importance. But, until we get to that point, we need to do exactly what Laura is doing and their agency is doing, is like meeting women around the corner where they can talk and deliver things and services. I mean, this is what it takes, is to really identify who has what technology, and if they don't have technology, to really have differential strategies to reach and engage them and figure out what resources. But it really goes back in terms of, a much larger structural issue that we need to tackle.
Yeah, I think you covered it. I mean, I'm grateful for texting and for the fact we found a texting platform that will allow people to at least privately communicate with us. And I think for all agencies that haven't gone this direction, I think people have to get on it on our end so that we're ready. And then I think the advocacy for clients, and we were saying here in New York that the DOE managed to find a lot of devices to give to kids in school that, that were found and like we could do that on a regular basis. We could let our client, we could make that be a budget item. I think someone was saying, how could we use the more, money in the community? We could make people have the devices they need to be able to communicate if we were committed to that for people who couldn't get them on their own.
I think in some of the efforts of transferring some of the funding from police departments to the community, that would be one that I would say is really essential. And you could do that community response to intimate partner violence that is taking police time more efficiently in making sure that everybody in the community at least has some access to phone or technology. That's just an idea.
That was actually one of the questions that we got just most recently. So somebody asked, when we're talking about defunding the police and heading towards more funding for community services, what are the best alternatives that need funding based on what you're both seeing to ensure safety of individuals who are stuck inside with their abuser, do not have options to simply do not want to leave? It's a great opportunity to talk about that a little bit.
Laura, do you want to say?
I was just saying, one of the things that people have been talking about is, we're of course focused very much on services for victims. I mean, there is a movement about like, what are we, is there movement or message or support also for people who are likely to use violence or use power and control? Like, is there any kind of campaign or, that should go toward that? I know that, in community violence interrupters and people who get in and talk and, de-escalate have made a difference. Like, is there any way to remotely do that with not only just the victims, but also the people who are, perpetrating violence? I mean, I think more has to go into looking at that.
Right. And the other thing I would say is that I think it's vitally important to ask the communities themselves how they can best use those resources to protect women and men from domestic violence. They know best. Let's get all the key stakeholders together. Let's get them and try to come up with a shared goals and vision and to make that collective impact. And I think they would generate solutions, communities that are highly burdened by COVID and highly burdened by domestic violence. And to do that, we really need to map out when, where, how domestic violence is happening in places like New York City and across the country.
I think there was a question about like, have the murders gone up? And I think part of it is, I think
we don't know.
We don't wait until like a year
know?
later. And then a year later, they'll tell us. I mean, we see
So a year later, they will tell us that's not soon enough.
No.
And that's what's driving me crazy, because, you know, we don't know. We will know a year later at the way data is collected and, you know, and sort of aggregated up. We can't wait that long. And this is one of my real frustrations of how do we get real-time data on domestic violence cases and deaths. So it's a huge issue, and I think one that we need to advocate for, and one that communities, if they were mobilized, could really press for that data.
That's great. Speaking around the issue of data as well, so somebody asked their presentation notes for Black and Latinx women. Are either of you aware of any data for those experiencing IPV during COVID-19 from Asian descent in particular?
Unfortunately, no, only what I kind of presented in different countries. So I don't know in this country what the rates are and broken down, but it's a great question. And I will go back and see with my, you know, the sources that I cited. I didn't see any that broke it down by race, ethnicity. And again, that's a problem because we know that it's not equally distributed across the country. And so we really need to have real-time indicators yeah.
Yeah, and I think we're seeing it in all of our clients from all backgrounds. I mean, we're like not a research place, so we never have the data, you know, the data kind of like even in our own end that way. But I think, you know, a lot of also our Asian clients are experiencing like violence from the community, you know, in reaction to being accused of having the flu, that's, you know, the Chinese flu, and real like prejudice. So that has been like, and our staff. So I think that's been an added layer for clients who are going through this, like the fear that not only are they experiencing maybe domestic violence and fear of COVID, but also the fear of very specific targeted racism.
And if any of you out there in the audience have access to any data on the racial breakdown since COVID-19 of domestic violence cases, that would be great.
It looks like somebody just shared the link to an Asian Women's Center in New York. Chat just went away. In the community, so something that we can also look at as well. There's a question a little bit, to pivot a little bit, to get some more information about clients who have developmental delays and any programs that might offer remote services for this population as well.
It's a great question. Laura, what is Sanctuary?
I would say, I mean, the program that has historically been a lead on this has been Barrier-Free Living, which focuses on all kinds of disabilities, including developmental disabilities, but I have not had recent, I don't know what's going on there and how they're experiencing it. I mean, basically we're finding for children that we work with who have disabilities that doing this all on remote technology is a nightmare and not working as well. So I would imagine that it's having an disparate impact on people with disabilities, because a lot of the technology and the ways to access help are so complex that I would say
elderly. I mean, we have to think about the most vulnerable groups, and those with developmental disabilities, those who are elderly, I think are also ones that are gonna, or homeless. These are all ones that are heavily impacted by violence too, and we need to think about how we redouble efforts and have tailored strategies to reach and engage them.
There's another question about working with the police. And so there's a question about if anybody knows of anybody working with the NYPD in particular, or other police departments and partnerships specifically around, I think, IPV and COVID-19.
I don't know about IV and COVID-19. I would say that Safe Horizons in New York City has a large contract where they put advocates into each precinct, and they, you know, work hand in hand to support. They have, I think, 2 advocates in each precinct. One is a general, like, crime victims, and one is an IPV advocate. I mean, I will say that Sanctuary at one point had a part of that contract, and I will have to say that working with the police, we had to do presentations to the police, and it was the hardest audience I've ever presented to in my entire, like, 20 plus career. Like, it was really, the work is critical, but it's a very hard work to do. Like, you know, because of the culture and the kind of, like, the receptivity that I was not always seeing, you know, in the work that I attempted to do. But Safe Horizons in New York has really made that a whole, like, a major part of their work. And I think what they hope is by being present, by being there to kind of, like, well, I don't know how they're working remotely, but being present in the precinct, they were able to kind of be that person, to be a go-between and an advocate, and kind of, like, also educate the police.
Yeah, we have in some of our rolling out wings in different countries. In Kyrgyzstan, we had a whole initiative with training the police, and they actually are on the Wings Community Advisory Board, which we have rolled out in Kyrgyzstan and India. Also, we have an advisory board. I mean, they are a stakeholder. I mean, they are on the first response, and there are countries that have really adopted domestic violence units that are staffed by women, that are people who are really trained, that have advocates in them. So there are different ways that we can, I think, engage the police. But as Laura said, they're a gatekeeper, and there's one, you know, there's a particular type of stakeholder that we need to figure out, you know, the most effective ways of engaging.
And I think, you know, I think Eric Adams just said it well, the Brooklyn Borough president, that, like, you know, the beat officer is not well trained to respond. If you're training them to break down doors and they're not well trained to, like, interact with people who have mental illness, with people who are in distress. They're not, because they bring that same, the training that's for one kind of thing to everything they do. So I think that there's a lot of work to be done.
Yeah.
There's a follow-up question about this. So just more specifically, why was it hard to work with the police? I don't know if you want to expand further then.
Well, I mean, we just had to do presentations. We had to do, you know, and always makes me think of an old Hill Street Blues, when you talk to the people right before they go out. There's a name, roll call, you know, and we would be speaking to beat cops before roll call, telling them important things about domestic violence. And I just felt like, I mean, they listened because their officer was like, you have to listen. But there was no, like, engagement, or, like, and I think on some level they couldn't, like, if they asked a question, they would have looked like, I don't know, like, I don't want to say weak, but, like, there was kind of a culture that they all had to sort of act like they didn't want to hear what I had to say, and it was no big deal, and they're not social workers. And so I thought, here's these people who would want this information, and they'd be listening and asking questions, but it was like, it was not that. And I think part of it is the culture, like the culture. And again, these were not domestic violence officers who've chosen to maybe work in that area. These were just the general beat cops. But when someone calls 911, they're not getting a domestic violence officer. They're getting, like, the, you know, regular person who responds. So I think that's the challenge. Like, and I don't, I mean, I was just grateful when the contract was over, because I felt it's, like, so kind of hard not to, but I think someone's got to do that work. I mean, someone has got to engage. I mean, in addition to the fact, really coming to terms with the fact that the police are not the right people to respond to some of the things that we expect the police to be responding to.
Mm-hmm. That's great. I think we've covered a lot of the questions so far, which is really great. So I just want to reiterate that we will be sharing the slides. There's been some requests also for the materials, Laura, specifically the safety planning document that you shared, and some of the conversations in the chat. And so hopefully we can make all of that available. Laura and Louisa, I don't know if you want to end with a few thoughts before we wrap up.
I just want to thank you both, and really thank the audience for showing up. I know, as I mentioned before, I know this is a tough time, and I just really appreciate your engagement, your questions. It's been a delight for me. Thank you.
And to, you know, I want to reiterate that, and also to say that I think discussing racism, COVID, and gender-based violence and all these intersections is absolutely imperative. We cannot, like, separate out and be like, this is only over here and over there. Like, these things are so intertwined, and maybe all of this is really exposing and putting it in our face so that we really can work collectively make change.
I think that's a good place to end with. And there was a comment early on that Louisa answered in the chat, in the Q&A box, where somebody brought up the great point about the need for a name for the three co-occurring pandemics of racism, IPV, and COVID-19. And so that especially—
that is the future. We need to do that. Yeah, we need to keep on moving this agenda forward. Thank you.